Thank you. All right, thank you so much. And now we have our next speaker, which is Dr. Dan Culver. He's going to be speaking to us about prednisone and the good news, other options beyond prednisone. So Dr. Culver is a pulmonary physician with a long-standing interest in sarcoidosis, including lung and all other forms of the disease. He developed the largest sarcoidosis clinic in the U.S., the Cleveland Clinic Sarcoidosis Center of Excellence, which he led until 2019. He is now the chair of pulmonary medicine at Cleveland Clinic. He is the immediate past president of the World Association of Sarcoidosis and Other Granulomatous Disorders, former chair of the FSR Scientific Advisory Board, and a member of the ASOG Executive Committee. He has published numerous scientific papers on pulmonary, cardiac, neurologic, and ocular sarcoidosis, as well as small fiber neuropathy and sarcoidosis. Dr. Culver, thank you so much.
Good morning, everybody. Thank you, Heidi. Thank you, Michelle. It's a pleasure and an honor to be here. It's always so energizing and grounding to talk to people who are living with the disease. And nowadays, I have a more administrative role than a clinical role, but I can tell you that the best parts of my week are the times when I'm in clinic and I'm seeing patients and we're working together to try to achieve something. So I do the administrative part, but the patient part is what really keeps me going in the space. So thank you for being the half of the equation that feeds me. I'm going to talk a little bit about treatment beyond steroids. And just to frame this a little bit, I'm going to focus on medication treatment. And as Dr. Bonham pointed out, there's a lot more to treating sarcoidosis and dealing with the symptoms than just throwing immunosuppressants at it, right? However, in the interest of time today and to focus on, I think, what Dr. Sharp and Heidi wanted me to talk about, I'll focus on some of the medications. So here's what I'd like to discuss today. I'd like to talk about when do we treat? To me, this is the hardest question. It's not how, it's when. Who gets it and who doesn't? That's a tough discussion. Moving beyond steroids, and what are some of the options? And can you hear me okay? Everything okay back there? Good on the volume? Okay, thank you. All right, so as Dr. Bonham mentioned, there's really two main indications to treat. It's not to make the x-ray better. It's not to make the breathing tests better. It's not because the PET scan shows something. It's not because you have something in your blood that says there's inflammation. It's because of danger or quality of life. And I think Dr. Bonham went through that very well. I think about this a little bit differently than other people. I think this is like a 2x2 matrix or a dimension. On one axis, you have how dangerous is this, from a little bit of danger to a lot of danger. A lot of danger is like you have it in the brain or something. A little bit of danger is maybe you just have lymph nodes in the lungs that aren't causing any symptom. And on the other axis is how much is this affecting your quality of life? And if you plot those two things, you'll come up with really dangerous and really symptomatic. We would all agree to treat that. That's the red. Or completely non-dangerous and no symptoms, and we would all agree we don't need to treat that. And then you have these two yellow boxes, right, where it's really dangerous but there's no symptoms, or there's a lot of symptoms but no danger, and that's where we really have to have a discussion. And those discussions are different. As Athol Wells talks about, that you'll hear later, 50 different deals for 50 different patients. And I think that's what we do. That's what we try to do anyway. So here's how I think about the decision to treat. I think about it like a teeter-totter. And you'll notice that the focus of this teeter-totter is what? It's your preferences. Again, this is a shared decision. We have to chart a course together. I can give you some suggestions. I can give you some tips. I can jump up and down sometimes if I feel strongly about it. At the end of the day, you are the fulcrum of that decision. And what makes the teeter-totter go up and down? It's a few different things. And I listed some of them here, and I think my slide just jumped, didn't it? Okay, sorry about that. So you can see symptoms, impaired organ involvement, clear-cut evidence of disease activity by however we want to look at that, bad kinds of disease, things that are historic, what we've seen before, And then on the other side, maybe features that suggest this is more likely to go away. Maybe it's quiet. Maybe there's a good reason not to treat. And so I think that's the first thing is, are we going to treat this or not? Now, what clues can I use to help decide? And there are some clues that we can use to say, hey, you're probably not going to do well, or you're probably going to get on the good foot over here. So one of the clues, that you got the James Brown reference there. One of the clues is the number of organs that are involved. And this doesn't mean that I do a PET scan and I find every little ditzel on the PET scan, because that's not what any of these studies show. This is there an organ involved that we can see walking in the door that's causing problems, that's easy to see? In the US, at the time of diagnosis, about half of the patients only have one organ involved. About half of the patients have more than one organ involved. And this is just a plot showing 1 and 2 and 3 and the numbers of people in this large study that had those. And you'll notice I'll show you a lot of data slides today. I like seeing data. That's how I really believe what's going on. I think we should be rigorous and we should use data. And these are the same data that I show to the physicians. These are the data we use to make our decisions. So if you have more than one organ involved, I start to get more nervous about it. Boy, this thing just jumps around, doesn't it? Okay. This is a study that has not been reproduced, but I think it's a really interesting and cool study. It's from Japan over 30 years ago. And they just asked a really simple question. If you look at the number of organs involved, which I think is on the top, is that on the top? Yeah, that's the top. And you look at how people just do in large baskets. I can do everything I want to do. I need some help. I need a lot of help. Look at the number of people who have 4 or more organs involved. 2/3 of them will need some help doing their stuff, and 1/4 of them are going to need a lot of help. So those are the people that we have to really be the most aggressive and really focus on. Those are the ones who have a lot of danger. Wow, what is happening here? All right. Now, we know in sarcoidosis, a lot of people are going to have a spontaneous resolution. That's really good if it happens to you. If you're the person who doesn't have a spontaneous resolution, you're saying, well, what about me? Because the conception out there with the NIH and drug companies over the years and the lay press and a lot of other people, including some of my own colleagues, is, oh, this is a benign disease that just goes away, who cares? It's not IPF. IPF kills people. Sarcoidosis is no problem at all. Right? Has anybody heard that before? Yeah, you have. We all have. If you're in the group of people where the disease does not go away and where it causes problems, that doesn't sound like a very accurate assessment, does it? So as a physician, what am I trying to do? I'm trying to identify who is really at risk out of all the people who come in the door. And we have some rough numbers. So just for pulmonary disease, we know that some people will get bothersome disease. That means symptomatic disease. And of those, some of them will have persistent disease that doesn't go away. Of those, some of them are going to get on a pathway where they continue to progress. And of those, and this is lung disease specifically now I'm talking about, some of them will develop scarring, which as Dr. Bonham described as irreversible, and which really is the cause of a lot of the really bad outcomes in sarcoidosis, whether it's related to infection, whether it's related to high blood pressure in the blood vessels of the lungs, pulmonary hypertension, or whether it's related to something else. The scarring is really the people who are in the most challenging situation with sarcoidosis. And at the end of the day, 5 or 10% of people who started off at the beginning with pulmonary sarcoidosis will end up with one of these really bad outcomes. So those are the people that we are really, really quite concerned about when we see them in clinic. And there are better and better tools now to try to start to identify those patients. I'm going to try using this thing. I'm really just not competent with a keyboard, apparently. Another thing I want to point out is that the danger depends on what organ is involved. And again, I mean involved in a way that's meaningful. Not that I found a ditzel on the PET scan, but involved in a way that's meaningful. Here's a series from Dr. Judson a few years ago looking at the organs that need treatment the most. You can see the heart and the brain are up there at the top. Some organs, like liver involvement, rarely need treatment. And it's better to keep your powder dry and not expose patients to toxicities. Now, one of the other real challenges I have when I'm thinking about treatment is we can't just say, oh, you have an organ involved, now we know how to treat. We got to marry that together with the symptoms. But as you all know, having lived through this disease, sometimes it's really hard to link the symptoms to the sarcoidosis. right? Because you're allowed to get other things, as you just heard: rheumatoid arthritis, knee osteoarthritis, anything that comes along with getting older. And so as a physician, I have to think about a symptom like shortness of breath and think about a range of causes that can be associated with that, because I did not want to expose you to a potentially toxic medication to treat your shortness of breath if that's not the thing that's going to make it better. And in fact, the shortness of breath is from something else, like one of these other things. So a good physician in sarcoidosis world will go through a checklist and just not make the assumption that every symptom is due to sarcoidosis. We also can't make the assumption that every symptom is not due to sarcoidosis. In fact, I think the thing that keeps us in business is in the sarcoidosis centers is really trying to make that judgment. So here are some categories I think about for symptoms, and I'm sorry, this may or may not display very well in the back, but these are the things I think of when I try to basket symptoms and think about whether I'm going to treat patients. Some are granulomatous inflammation, that's sarcoidosis. That can cause a lot of symptoms. We have medicines for that. We'll talk about that in a minute. Some of them are consequences of sarcoidosis, but that are not granulomas. Fatigue is not due to granulomas, at least not directly. Fatigue can persist for a long time after the granulomas go away. So can cognitive dysfunction. So can joint pain. Are all the medicines in the world that are anti-granuloma medicines going to help those? In some cases they do, but in most cases they probably don't. So again, I'm thinking about the risks and benefits of these medications. Sometimes the way we approach it is just to give a trial of the medicines. We say, look, let's try it for a little while and see what happens, but let's agree on how we're going to measure that and when we're going to decide that this was successful or it wasn't successful. I think a thing that we've not recognized well in the past is this third category, and that is a lot of symptoms that patients with sarcoidosis get are toxicities of the medications which were supposed to be good for you, right? Steroids, right? Anybody have a toxicity from steroid? Right? I think we could fill our whole clinics up with that. And I think a lot of what happens to people over their life with morbidity, that is other diseases, and even with the increased mortality we see in sarcoidosis is due to toxicities of the medication as often as is due to the disease. And then the fourth category is unrelated to sarcoidosis. And you're allowed to have other things, like we said. The other piece that we have to think about when we think about treating, besides these buckets, are there active granulomas? This is a really hard thing to get our hands around, and we don't have good markers for it. On the left, you have clear-cut active fire, right? We know we have to put water on that to put it out. On the right is burned out sarcoidosis. There's a lot of damage here, whether it's cognitive problems, whether it's lung dysfunction, whether it's a heart that doesn't work as well as it used to when you were 18 years old. But water's not going to do a lick of good for this. In fact, it's probably just going to hurt. And I think where a lot of patients actually are is in the middle, in a smoldering state. And how much water you're going to put on that is a thing, again, we've got that teeter-totter, right? So this is something we wrestle with a lot. There are some markers for this. I can tell you that I don't buy any of them yet. There are blood markers. I put those in some color up at purple. I put them in purple for sarcoidosis. They help me lean. They help me go one way or go the other way. None of them are definitive. And if you're using these in isolation to make a decision about treatment, I think that's a problem. So these help us lean, but they're only one piece of evidence. The PET scan is the newest kid on the block. It shows inflammation around the whole body. In fact, I'll show you a PET scan. There's a PET scan. Okay. It can find a lot of inflammation, but it doesn't tell you whether or not you need to treat the inflammation. And we also do not have evidence. We have zero evidence today. You guys correct me if I'm wrong on this. That using PET scan to decide who to treat makes a difference to the outcome. We can make the PET scan better with steroids or other medicines. We have zero evidence that using PET scan makes a difference to the outcome. This gentleman here hurt his back playing golf, got a lot of imaging. They found some stuff. They did some more stuff, found more studies, did more stuff, did a PET scan. Whoa, this is bad news. We better treat this guy. His back problem was from his golf injury. It had nothing to do with sarcoidosis. He never needed treatment. We tapered him off the therapy, and he did fine. So just because you have something on a PET scan does not mean it has to be treated. A judgment has to be made. Now, one thing Dr. Bonham mentioned as well, and I'm just going to shift here a little bit, to how we treat it. And you guys are the experts in this. I'm not the expert in this, but we've been interested at the clinic for a while in the toxicities of steroids, and so we asked a question, if you get put on steroids, what does it mean to you over time? And we have these things called Kaplan-Meier plots. There will be a quiz on that later. We're just looking from time 0 on the x-axis, and we're following patients along over time. And we're asking, did you ever get steroids for your sarcoidosis, or did you never get steroids for your sarcoidosis? And if you did get steroids or you didn't, how many people got high blood pressure? How many people got diabetes? How many people got obesity? How many people got eye complications? How many people got cholesterol problems? How many people got osteoporosis? And we counted those up over time. And you can see the ones who got steroids have a lot more of that. So their rate of getting those things gets close to 60% in this study. Okay? You could stop the steroids. The average dose of use of steroids in this study was 6 months long, and people still keep getting those problems. So steroids change something in your body, and it's hard to go back. It's hard to go back. So we as a field are moving away from steroids, and we're thinking of other ways of doing this. Wow, this thing is like a poltergeist or something. Must be on an automatic advancer, or it's just telling me I'm going too slow. That's probably what it is. Dr. Bonham mentioned this. Maybe this step-up approach where we start with one thing and wait till you get toxicity, or we wait around 6 months to see what happens, and then we add another thing, and then we add another thing, and then we move over here. Maybe that's not the best way to do it. So we are moving into a paradigm now of step-down therapy or a more aggressive therapy at the outset. And especially for certain organs like lupus pernio or bad neurologic disease, my theory is let's start with 3 drugs. Start with 3 drugs right out of the gate. Get the disease under control and then back off. Okay? And let something that's non-toxic control the disease over time. So I think this is individualization of therapy, and that's a similar thing that's just posted here. Right? Some patients have a really good prognosis. They only need a short treatment. Maybe they just need a few months of therapy to get over the hump. Maybe they have some symptoms that are across their whole body. They feel flu-like, and it's early days of their sarcoidosis, and they need something that's going to kick in real fast. So steroids might be fine for them. Lower doses than we used to use, but steroids might be good enough, and then you get off fast. Other people you may know you're in for the long haul right at the beginning. Look, if you see somebody coming that's going to take long therapy, that's going to need a lot of treatment, why are we starting with steroids and then only later adding another drug? So those are people maybe we should be thinking about these agents right up front, and I think in fact that is happening. And I'm going to go through some of the agents now with you. So these are the main immunosuppressant options over time. From when you heard Mortimer's malady first get described up to now. And you can see that some of the therapies that were used at the beginning are ones that we would probably choose not to use nowadays. I don't know about you guys. I don't use too much arsenic in my practice anymore. Tried to move away from that. Every now and then got to pull it out of the drawer, but most of the time I don't use it too much. I can show you the ones that I mostly use. Those are the red circle ones. And I'll show you another way of looking at this. Here's the list I could come up with of all the anti-granuloma medications. Okay, these are all the ones that we might think about using. And I'm just going to ask you just for a little audience participation here, and if you don't want to share, that's okay. How many of you have been on more than 3 different medications for your sarcoidosis? Anybody been on more than five or more medications for their sarcoidosis? Okay, not too many, but a couple, right? And there's a lot of like whack-a-mole, like Heidi was describing. Okay, now these are drugs we've mostly borrowed from other diseases. Here's the medicines I have used and practiced in red, probably about half of them. Some of them are new and I'm not quite convinced about them or just haven't had the opportunity to do it. Some of them I don't quite believe in. These are the ones I've used in practice. The problem in sarcoidosis is we haven't been very good at studying these drugs. We've just borrowed them from other fields. Okay? So if you talk about studies that actually really rigorously look at these, we want what are called randomized controlled studies. That is, some people are getting the medication, some people are not, and we're comparing those ideally like a scientific experiment. So how many of these have actually been subjected to a scientific experiment to see if they improve things? And these are not necessarily good scientific experiments in many cases, but you can see most of them have not. And because of that, very few of them are approved by regulatory bodies for sarcoidosis. Only these two, and these are from a very historic approval process that didn't really require randomized controlled trials. Now, one piece of news I want to leave you with today, which is a good piece of news, is that we now have some industry entering the field, and we're starting to see real trials in the space. And in fact, we just wrapped up the enrollment of the first ever phase 3 trial. That's the last phase before you can apply for regulatory approval by the FDA. So I'm really hopeful right now that we're going to start to see industry getting interested in this disease, coming in and finding some ways that are not just borrowing from other diseases, but actually have something directly to do with sarcoidosis to help us manage this better. Many of you have used these things. I use a lot of these. I don't like steroids. I try hard to get people off of steroids. Here are several of the drugs that I use quite a bit. Dr. Bonham talked about some of these already. I will say methotrexate is the most popular when you're talking about really solid second-line agents, but none of these have been compared head-to-head. We use a lot of leflunomide in Cleveland. I think it works a little faster. I think it's a little better tolerated. But I can't really tell you that on every other Tuesday I won't have a methotrexate day and be giving people methotrexate instead of leflunomide. I really think, there's no great way to compare these, and really it should be what's tolerable and what's doing the job for you. You can see that all of these require some monitoring because they have potential toxicity. But in general, I think if you give me the choice, would you take prednisone or would you take one of these in terms of toxicity and risk and what I'm worried about? I would take any of these before I would take prednisone. The one drug that Dr. Bonham mentioned that I don't have up here is mycophenolate, and that may be a personal bias. I'm not a huge fan of mycophenolate in sarcoidosis. I think the data for it are really kind of flimsy. It works pretty well in other interstitial diseases, but we can, maybe that's a good pro-con debate for next time, Kathy. Next year, instead of fibrosis, we can talk about mycophenolate. How am I doing on time, Heidi? Eight more minutes. That can be done. Perfect. Okay. I'll talk a little bit about where we're going now, I think, because you guys have heard about many of these medicines before. That's nothing new. I think we're getting more scientific in our approach. And as Dr. Bonham described, sarcoidosis is really a reaction of the body to something that it sees, what we call an antigen. And in this case, two cells from the immune system are talking to each other about this antigen, and it's a little bit like a little political convention. They're talking about the antigen, and they're getting riled up. And the immune system gets riled up. That's inflammation. And part of how they do that is they send these messages to each other with proteins. And those proteins are things like tumor necrosis factor, interleukins, chemokines. These are all different kinds of proteins that signal the immune system to have inflammation. And in sarcoidosis, there's a package of those things. And so therefore, all of those are targets to block with medications. So when we talk about biologic therapies, we're talking about medications that specifically try to knock out one of those proteins. I think about that as like a precision weapon, right? Rather than carpet bombing the immune system, we have a precision weapon that's just going after one of the particular proteins here. And when we first started using TNF, anti-TNF agents like infliximab and adalimumab, that's Remicade and Humira, we thought, the immune system's going to find other ways to get around this. It'll escape. Turns out this is a really good way to block granulomas, and TNF is really important to constructing this rugby scrum of immune cells that we call granuloma. And so that's one of the therapies we use quite a bit. Now the antigen is in the middle of this. That's the protein that started this whole problem, right? And you would think, oh, let's just get rid of the antigen and we'll solve this whole problem. The Culver hypothesis of this, or the Culver viewpoint on this, which is not everybody's viewpoint, so I want to just say this is the Dan Culver view of the world, is the antigen doesn't really matter too much. I think there's more than one thing that can probably trigger sarcoidosis. I think it's around us in the world, and it's all more about the immune response. So here's the way I think about it. I think about you as a person, like a blue box here, or a black box, and you have genes, you have markers that happen to genes, you have some factors, and you have some exposures that have happened to you over the life, and you're going along just fine, and then an exposure happens, and it's probably different in different parts of the world, or it's different for different people, and your immune system is reacting to that. So it's not that the exposure's out there in the world, it's how's your immune system going to react to it. And then you get sarcoidosis, that's the red circle. What happens after that? Do you get on the good foot or not? Depends again on all those factors: genes, epigenetic changes, host factors, and modifier exposures. Some people get it in the heart, some people get resolving disease. All of those features are likely to weigh in. I'm not saying that the trigger might not also influence the outcome of this, but I think the trigger is probably not the main place we should be focusing. So how do we use this to look at therapies? Well, first of all, I'm not focusing on getting rid of the trigger. I'm looking at ameliorating the immune response. So here are some of the things I talked about before: antimalarial therapies, steroid-sparing therapies, TNF antagonists, and these biologics, right? Those are the precision things. There are also mTOR antagonists, which is another branch of the immune system, which is really fundamental for regulating how the immune system proliferates. And finally, that older drug, which is a cousin of steroids, but not quite the same thing as steroids, which is repository corticotropins. Now, many of these have generics, which are nice. That gets you better access to the medication. The biologics don't have generics. They have biosimilars. Biosimilars are not molecularly, chemically identical to the parent drug the way generics are chemically identical. So generic methotrexate, generic leflunomide, let's just say that because the brand name is Arava. Generic leflunomide is chemically identical to Arava. That's the requirement. Biosimilars are not chemically identical, but they have to be able to show that they have the same biologic effect. So if you're using Inflectra or Renflexis or one of the TNF biosimilars, we think those are probably pretty similar. Studies have suggested that they are. But that's the difference between a biosimilar and a generic. And then I listed a couple of the biologics that have a little traction in the field. And I have to say, I don't think any of these are ready for prime time yet. Rituximab, tocilizumab, and tofacitinib. Of those three, I'm the most excited about the JAK inhibitors, tofacitinib. And there are a number of other JAK inhibitors. That's just one of the examples. I think we're going to see that that's going to be a really important therapy in the future. And I'll just use the last couple minutes to talk about why I think that. And that has to do with where we're going with omics. So in the past, we kind of said, oh, I think this one might be important, or I think that one might be important. That's hypothesis-driven research, right? So if you're thinking about a football league, you're thinking about what is the most important position on the field. Somebody might say, well, what distinguishes the teams that have won the most championships? It's having a really great quarterback. And somebody else might say, oh, you need a really great linebacker. Okay, but we would just be arguing with our opinions. We could test that by comparing teams with really good quarterbacks and really good linebackers, but it's complicated because maybe the teams with good quarterbacks also tend to have good tight ends, right? So you can see right away it gets really complicated. These newer techniques, these omic techniques, don't come in with preconceived biases about what's important. They measure a whole bunch of proteins or a whole bunch of genes or a whole bunch of metabolites, and they ask, let's compare groups of people with sarcoidosis who are getting better and groups of sarcoidosis who are getting worse, and we'll compare this across thousands of genes and across hundreds of patients. And we can start to do statistical analysis to then say, in all of those, which are the most important. So you end up with these networks, and I just put two of them here. One is on the left and one is on the right. That lets us say, here are primary targets that really repeatedly show up. And it turns out that it's the left tackle that makes all the difference, and that's the single thing that makes the biggest effect on whether or not you're going to win a championship in football or not, even though quarterback is really important and so is linebacker. So these are what these omic techniques allow us to do. They allow us to get out of our biases and come up with new targets, new ideas for what might be working. So I think that's where you're going to see more biologics coming into the space, and I think that's one of the reasons why we're going to make good progress in this field. Now, Dr. Bonham mentioned clinical trials. There are a number of clinical trials that have been happening. I just want to point out that this is really starting to accelerate, and I have some of the clinical trials here, not all of them. For example, Zentria has a trial going on right now that I don't have on here, but there are a number of these. The phase 3 one is the one that's nearest the bottom. We should get a readout on that in about 13 months. So in about 13 months, we should know whether or not that's been helpful. So what can you do? Be empowered. Negotiate with your physician. Come in and say, hey, let's work on charting this course together. Bring your questions prior to the visit. Write them down. Be specific with the questions. What are you expecting this drug to do? How are we going to know if it's effective? When do you expect it to be effective? What are the other options? Going to make a push for engaging with trials. I want to say that not everybody qualifies for trials, and when you're doing a scientific experiment, which is what these drug companies are doing, this is a good kind of scientific experiment, but it's still a scientific experiment. We want to be really confident that we have clean populations that allow us to really see if drug A is better than placebo or better than drug B. And so for that reason, if there are other things going on in the patient that might cause noise in the answer, those patients usually don't qualify for trials. That doesn't mean they won't be able to get the drug if it's approved. It just means that during the trial, we have to be as clean as possible. It doesn't mean your doctor doesn't like you. It doesn't mean your doctor doesn't want to enroll patients in trials. It means that the FDA and the sponsor are really trying to be tight on having a real clear answer rather than wasting everybody's time by having a lot of noise in a trial. And finally, as you're all doing just by showing up, and I know you do in other ways, please advocate for the disease. It's been an honor and a pleasure to talk to you today. Thank you all for your attention.
Time for questions.